This is our panel on the power in the vision for GANSID. That will start now and runs for about an hour. Bryan will be your moderator for this session. I'm an emergency physician at the University Health Network in Toronto, Canada. And I am the today. Want to remind you that you can post your questions either using the Q&A button at the bottom of your screen or in the chat. We'll be hearing from 3 experts in the period. And then there'll be an opportunity to complete a poll with your reflections and impressions about the session today, which will be very helpful for all of us. I want to also remind you that in Feedloop, you can reach out to Dapo Ajisafe through the networking tab if you're having any technical issues. And you also have the option of participating in the language of your choice. At the bottom of your screen, you can click on the Show Captions button for those options. Okay, so let's begin. I'm going to begin by introducing our impressive speakers this morning, starting off with Cesar Garrido, who is the president of the World Hemophilia Federation. He was born in Caracas, Venezuela. He has 2 sons, one of whom has hemophilia A. At the ABH, he's been a key member of several endeavors, including the creation of new diagnostic laboratories in Venezuela and campaigns for testing and diagnosis of people with hemophilia in Venezuela and Latin America. He was also part of national programs that increased access to factors, developed outreach and identification campaigns, increased access to education, and set up regional medical workshops for people with hemophilia. He was also a developmental manager for a strategic alliance of more than 45 countries policies. Cesar was a member of the WFH Board of Directors from 2002 to 2010 and a lay member from 2014 until his election as president in 2020, a responsibility that must be fulfilled until the year 2024 at least. Cesar will be joining us by video recording. Now, please let me introduce our second speaker for this morning, Mr. Riyad Elbart. Riyad is the lead member of the thalassemia community in Canada and has served in prominent roles on the board of directors for the thalassemia of advocating for patients across. Bryan has been instrumental in maintaining strong collaboration with various partners and stakeholders, including health and hospital. Bryan has also been serving in the International Federation 1998 and has been honorary board member in 2018. He is a member of the organization and a board member of the Network of Rare Organization. I believe that there was a connection issue there and unfortunately interrupted my introduction for Mr. Riyad Elbart. Riyad in building our network partners and including directors of thalassemia 1998 and has been in 2018. We're a Canadian organization for rare and rare organizations. Thalassemia patient who has acted as the patient's voice at forums and meetings at the national, regional, and international levels for many years. And we're grateful to have him here with us today. Our third speaker this morning is Professor Adlet Inati. Adlet is a professor of clinical medicine at the Lebanese American University School of Medicine. She is chairperson of the Department of Pediatrics at the University of Balamand and head of the Pediatric Hematology Oncology Division and Sickle Cell Program at NINI Hospital in Lebanon. Professor Anati received her MD from the American University of Beirut and completed her pediatric residency and hematology oncology fellowships at Johns Hopkins Hospital and Boston Children's Hospital and Sidney Farber Cancer Institute, Harvard Medical School. She is American board certified and a member of Alpha Omega Alpha Medical Society. Professor published and is steering committee multiple global trials in hemoglobinopathies and congenital bleeding disorders. She is the founder and president and the NGO Road Safety and Free Healthcare Delivery and Awareness. Her ultimate passion remains mentoring young physicians to become expert scientists and compassionate healers. So 3 very exciting speakers for us in this session this morning. We're going to start off with the video from Cesar Garrido. So Dapo, I'll ask if you can please play the recording from Cesar for us. Thank you.
Hello, good morning, good afternoon, good evening, depending where you are living. And I want to thank the organizer of this important event, GANSID 2023, for the invitation and with the facilitate me to be sharing with you. And I just want to let you know that I am Cesar Garrido, the president of the World Federation of Hemophilia. So I pretend to share with you the meaning and the importance to be organized like a international umbrella organization as WFH. So has been possible to improve in the last 60 years. So working as a national organization, that is the reason that we nominate national member organization, that patient organization who represent each country. I mean, we recognize just one organization in order to be stronger, that if you disseminate the efforts. So hemophilia, as you know, even is a rare disease, is not properly something that we have a high population. So we can work with the small numbers, but it's possible to demonstrate that together is possible to obtain better benefit and to be more effective. We were founded in 1963, and at the moment we gather 147 organizations. It means 147 countries, and our organization is recognized by the WHO, so that give us an endorsement and demonstrate that so important in terms of health we are. So if we are not an organization, it's almost impossible that someone receive this kind of the category. Working with WHO, as you know, is extremely important. So we are the WFH provide a global leadership to improve and sustain care for people with inherited bleeding disorders, including von Willebrand disease and the women and girls with bleeding disorders as well. It doesn't matter where they live, religions, culture, and genders. Our vision, the WFH vision, is treatment for all. So because that is very challenging to obtain and to reach out the treatment for all, so we add and we have to comment that the best treatment possible in each country, depending of course on several aspects, but the most important, it has been demonstrated the income level. So in those countries, low income countries, so the situation, we try to understand that the best treatment for them could be something that maybe is not the same treatment in developed or high or middle income countries. The inequity and in diagnosis is part of the consequence of this kind of the income countries condition. So the inequity in diagnosis obviously will means inequity in medicines and treatment. So we, thanks to our data, we has been working, collecting data from different sources, but in all of them has been demonstrated that the worst scenario is in Africa, Western Pacific, and South Asia. So that is something that our strategy must be customized for that region, different that we implement several strategies in Europe, Americas, or Middle East. So that is thanks to that research. We also know that only 14% of adults and 60% of children with severe hemophilia worldwide have access to prophylaxis. And this is impactful if we consider that prophylaxis is the best treatment recommended by the expert and established in our third treatment guidelines edition. So the prophylaxis is something that prevents the patient bleed, and that in order to save their joints and the consequence for the future. In inequity in access to treatment, we have very curious number. For example, we have just diagnosed almost the 35% of the population estimated. So we have a gap, almost 75% they have not diagnosed. But these 35% or almost 28 between, depending the region, of global population access 82% of the available factor A worldwide. So that is another challenge important. So available medicine for the small population in comparison with the highest population, 82% of the access. The best way that the WFA recognized to work with the obtain the benefit and influence the public health policy is the national member organization. Very clear to explain before, and represent the best interest, usually conformed by patients, leaders, and in many cases together with the healthcare providers as members of these organizations. The normal life on the environment of organization is really complex. I won't be reading deeply, but the point is that it's impossible that just one person assume the responsibility and be successful living amid of these different establishment. For example, the competition, the supplier, the regulatory, the user, and the environment, general environment with many challenges that they have to face. So we need a patient organization in order to be effective. We want to achieve, well, we need to identify patients, because if we identify, we will have a number, and it's possible to gather that information, and it's possible to design a strategy, and it will be possible to improve access and care, designing a specific strategy in order how and where and who we have to teach, we have to train, we have to be working with them. And finally, increase the government support, because it's impossible to sustain the care for any person with hemophilia or other bleeding disorder without the participation from the government and from the health authority. So the advocacy in front of this authority must be implemented by the patient organization, of course. This is just an example, a final example about how when the patient is involvement, helping to design during the purchasing process and during the tender to obtain lower prices. So it's not just the participation from the patient organization as well, but working with the group of treaters. So as conclusion, the tender process results in lower prices, as has been demonstrated in the previous graphic. And where both are involved, I mean the treaters with the patient organization, the prices are lower for all products. So this is just an example, very tangible example that is possible to understand the importance to work as very disciplined patient organization. I just want to add that in many cases, our organization must be reviewed, and for that reason, the WFH implement an assessment of the national member organization in order to help. It's not in order to criticize or something like that. It's in order to help this organization be stronger in several aspects that maybe during the assessment could be demonstrated that they have weaknesses. So for us, our organization, the international organization, the global international organization, I mean the WFH, is this. I mean, we gather the participation from many volunteers. Even we have a very important, outstanding, professional staff member. So that is part of the combination that this successful organization for more than 60 years old, even we are a 60 years organization, we have implemented a strategic plan every 5 years in order to be updating, in order to be at the same time and working on the right track with the new challenge and new era. So thank you for your attention, and well, I am at the order, and if you have any question or doubt, please just submit and send me by email or something similar to be possible to keep contact with you. Thank you.
Thank you so much to Cesar Garrido for sending us that very informative video. Great examples of global action at work and the importance of collaboration. I'd like to welcome our next speaker, Mr. Riyad Albard, to please begin.
Thank you, Dr. Bryan, and thanks for the organizing committee for inviting me. I'm going to be shifting our talk in regards to today's topic, which will be on collaboration and unity among inherited blood disorders, more or less talking about the collective impact. So first, GANSID. What is it? I mean, it's established to identify common purposes among inherited blood disorders and embark on cross-disease while lending its voice to disease-specific advocacy initiative to meet the needs of people living with inherited blood disorders, no matter where they live in the world. So basically, it's an organization of organizations and stakeholders, and it's anybody that's working on inherited blood disorders to advance care, the treatment, the research, capacity building, education in regions of the world that are facing acute challenges for developing better healthcare systems, and where there is poverty and lack of disease awareness among the disease populations and the community in general. And we hope to shape and advance the efforts that ensure the promise of new inherited blood disorders innovations can be fully realized for all patients. We know there are many inequities around the world for treatment. Even in one country, you'll have one region that have full benefits and some areas don't have any or very little. So the Global Action Network for Sickle Cell and Other Inherited Blood Disorders is to strengthen the advocacy skills sets for patients, organizations serving these disease or disorder communities through training, mentorship, and cross-disease collaboration. And again, who we are, we're a global network of patient organizations, healthcare providers, health organizations, researchers, professionals, and academic societies and industry partners that serve people impacted by sickle cell disease and other inherited blood disorders, just so we are all on the same page on this. Collective impact. It's a network of community members, organizations, and institutions who advance equity by learning together, aligning, and integrating their actions to achieve population and system level change. And that's basically what we're trying to do with GANSID. And the essential elements, or some of the essential elements, is common agenda, establishing shared measurement, and fostering mutual reinforcing activities, encouraging continuous communications, and maintaining a strong backbone, which is our organization, our board, and definitely we have Landry as the leader, which is excellent. And I want to talk about the Canadian experience in terms of collaboration with other groups. For many years, I've been part of the Thalassemia Foundation of Canada and served as president, vice president for most of the time that I've been on that board. And we started as a Thalassemia Foundation of Canada to do collaboration with the sickle cell community from way back in 2001, actually even in 1999. We were faced with a crisis where the hospital in Toronto, the major hospital that provides care for both sickle cell and thalassemia, was capped, and we need to allow that program to expand, the adult program to expand. So we collaborated efforts and we did advocacy campaign, which took us a long 10 years to have a good program running. And it's actually become a model of care for other sickle cell and thalassemia clinics across Canada and maybe somewhere else in the world. So, and in 2007, we had the sickle cell newborn screening, which we knew benefits the sickle cell, but we support it, has very little impact on the thalassemia, but we did support it. And then in between 2010 and 2018, advocacy for sickle cell and thalassemia care in Ontario was established. And then we did the joint events for a while in between 2000 and 2007. Now, we established something in 2016, which actually Landry was heading that. And Landry and I, we worked a lot on that, which is called Ontario Hemoglobinopathies Patient Association. And I think sometimes we need to start to be very comfortable and familiar with using the term hemoglobinopathy rather than using sickle cell and thalassemia, because that's how health authorities see us, that's how healthcare professionals see us, and that's how hospitals see us. So we initiated a working group representing from both patient communities and some experts from Ontario clinics and centers of excellence from the Toronto and other parts of the province of Ontario. So we did successful advocacy in 2019, 2021, just at the start of COVID. And successful advocacy was that the Ministry of Health of Ontario was given additional necessary resources at 5 Ontario clinics and centers. And recently they are going to be helping us establish 3 more clinics. At the same time, there was legislation that passed through the Ontario legislation. It's Bill 255 declaring Thalassemia International Day on May 8th and a sickle cell World Sickle Cell Day on June 19th. So that's an awareness, and it's a start of recognition and start a lot of good things happening. In the same sense, we collaborate with the hemophilia and other rare blood disorders. This is something that we established in 2004. It includes hemophilia, it includes aplastic anemia and myelodysplasia, it includes also hereditary angioedema, it includes sickle cell, thalassemia, and now I think it's about 12 rare blood disorders. So I've been part of the group that initiated this back in 2004, which is almost 20 years ago. So this is a success. I mean, you can collaborate, you can have different groups working together on commonalities. So we worked on comprehensive care, establishing guidelines and trying to implement those guidelines for each disease group and ensuring a safe and secure blood supply. That's one of the common things we have. And supporting the members by sharing best practices. So we learn from each other, whether it's in governance, in advocacy, whatever it is that we could help each other learn. So developing skills in healthcare advocacy, that was one of the big things that we have been working on, and at the same time advocating for some of the common, or even if it's one group that has a pressing issue, we lend the voice for that one group, because by one person gaining, we all gain. So avoiding, and we also work on overlap and inefficiencies. So basically, why reinvent the wheel when we can learn from each other? So in a similar manner, globally, these are some of the commonalities among inherited blood disorders. There's a new curative therapies on the horizon, which are very expensive, and we need to have access to that. We have gene editing for thalassemia, hemophilia, sickle cell, and I'm sure there are for many others that are either in the pipeline or just a few years on the way. So we share healthcare teams and medical experts as well. So we need to establish comprehensive care programs and access to innovative drugs. We all need to remove the barriers to have access to the medicines. And at the same time, we have life dependency on blood, or even reliance on blood. So we have to ensure there's a sustainable, safe blood supply. Another one is newborn screening or early diagnosis, depending which disease group it is. And that's very important because that saves lives, that identifies the patients and identifies what treatment they're going to need. Treatment guidelines, which I mentioned earlier, so implementing those treatment guidelines as the standards of care across the country, or even in regions, sometimes you might need to follow that. As well, we all do patient education and caregiver education, and we also need to provide education for healthcare professionals. So are the things that we can work on together as GANSID. Now, in terms of thalassemia globally, the Thalassemia International Federation has been doing a lot of work and have a lot of successes in providing care and education on thalassemia. Providing advocacy, sorry, not care, but and support for the organizations. However, there is gaps, and these gaps I would identify as it's reaching out to small populations of thalassemia patients and or thalassemia communities in countries of low thalassemia incidence. For example, there are countries in Africa that have very small number of thalassemia, the same in South America and in the Caribbean. So how do you reach out to those patients and provide them the support? And I think by having them forming alliances with other patient organizations such as sickle cell or hemophilia, or maybe all three of them, then that would be great. We can also, as GANSID, provide advocacy training and support for these small thalassemia patient population to enable them to advocate for addressing the patient needs in their own countries. The other thing is, as I mentioned, strengthening collaboration among thalassemia and other blood disorders communities to establish stronger voice for inherited blood disorder patients, basically work together as one big group. And we have example of that in Trinidad and Tobago, for example, in Australia, Jordan, and I'm sure there are many others. And also, one of the main goals is to increase knowledge and education on thalassemia for healthcare teams in countries of low thalassemia incidence. Basically, a lot of the doctors who treat sickle cell might treat one or two thalassemia patients where you have very small number of thalassemia patients, and they might not have enough resources, or because they are too busy working on the sickle cell or the hemophilia, that they don't there's a gap on terms of the education and knowledge on thalassemia. Lastly, the GANSID objectives. So we are here trying to raise the profile of benign inherited blood disorders as a collective, similar to blood cancers. And we are trying to jointly identify commonality of purpose and opportunities for cross-disease collaboration. We're also trying to increase the number of patients with inherited blood disorders served globally, especially those living in low and medium resource countries, and to improve cross-disease collaboration where such partnerships would support improved health outcomes for more patients across international blood disorders. With the anticipated success of this today's and tomorrow's forum, we hope we can set the tone and start the continued coalition building with members and affiliates. Leave you with couple words of wisdom from Walt Disney. The way to get started is to quit talking and begin doing. And that's what we're trying to do. So thank you very much. Thank you for your time, and look forward to the discussion.
Fantastic. Thank you so much, Riyad. I love that quote at the end. Also, your slides on the commonalities for inherited blood disorders. I was taking screenshots and jotting down notes. I think that's a fantastic way to view the vision for GANSID. So thank you so much. And everyone who's listening, please do post your questions in the chat and in the Q&A. We will have a question and answer period toward the end of the session. And now our third speaker, last but certainly not least, I'd like to welcome Professor Adlet Inati to give us her talk. Professor Inati.
Thank you. It's a pleasure to be here. I'd like to thank Larry and the organizers for inviting me. And I pride myself in being a founding member and a member of the board of GANSID. So I thought I'm going to shift gears and talk from a hematologist perspective, taking my experience into consideration. And I'd like just to give you a very brief overview of inherited blood disorders, including sickle cell disease, even though they're labeled as rare, but they are not that rare and affect more than 20 million people worldwide. And because of migration, they have become global diseases, which means all of us need to be really oriented to their care and management. They're clinically and genetically heterogeneous, associated with so many complications. Fortunately, over the past decades, there have been incredible improvement in therapy with longer lifespan, but with this increased longevity, new chronic complications, and negative disease impact on mental and psychosocial health and quality of life are becoming more obvious. There have been a lot of advances in curative and novel therapies, and they have been very well achieved. But unfortunately, again, these are inaccessible and unaffordable in the majority of affected patients. So if you want to very simplistically lump inherited blood disorders, we can lump them into 6 groups. The red blood cell disorders, thalassemia, and sickle cell disease are the most common. They're single gene disorders that the most common single gene disorders, white blood cell disorders, platelet disorders, coagulation factor deficiencies. The commonest is von Willebrand's disease, but the most clinically significant is hemophilia. And the bone marrow failure syndrome with Fanconi anemia, really being one of the important bone marrow failure syndromes, and thrombophilia. So let me just take you to the reality of sickle cell and inherited blood disorders globally. What are the gaps, the challenges, the unmet needs? And I think, we have heard from Mr. Cesar and Riyad, excellent, elegant presentations highlighting some of these, but I thought I'll summarize them just, starting with delay in diagnosis, to fragmented and suboptimal treatment and care, and that inequity and gender-based disparities in healthcare delivery. And again, these are global issues. Unavailable, unaffordable treatment in high prevalence regions like Africa, like India, like Middle East, lack of infrastructure, comprehensive care centers, guidelines, unified guidelines, global registries, except in some registries for single disorders. But we don't have registries for this combination of disorders. And very importantly, that lack or dearth of dedicated and knowledgeable healthcare providers, particularly for adults who prefer to do adult oncology most of the time. Limited disease awareness on all fronts by the public, the government, patients, healthcare providers, caregivers, limited number of patient leaders and advocates, and political neglect and invisibility. So there's a lot of work to be done. Despite all the major advances in diagnosis and treatment, individuals living with inherited blood disorders still have poor outcomes of variable degree, depending upon which disease. You've heard about the World Federation of Hemophilia and the efforts in terms of care, not only advocacy, on TIF in terms of advocacy. They continue to suffer, particularly people like sickle cell disease, high morbidity and mortality, particularly in areas of limited resources, and that very vulnerable period, which is a pediatric to adult transition, where most of these people succumb to major complications or to death. High associated social and economic burden and poor quality of life and that social stigma, which continues despite all efforts and marginalization of affected patients. Some other facts on the reality that have been touched upon earlier. One of the good facts is that in low to medium resource countries, most of these diseases are treated by the same healthcare provider specialists at the same clinics or centers. What does that mean? That really provides a significant opportunity for having cross-disease initiatives that Riyadh was talking about to strengthen care infrastructure, improve that training and education of all stakeholders, not only healthcare providers, initiate awareness and improve health outcome. So from what you've heard from me, the challenges are the global health challenges for these disorders are too great and too many for any one organization or any one country to solve alone. This is why a collective effort among various stakeholders like GANSID is a priority to increase equitable access to care, support advocacy, and initiate, and that's very important, an inherited blood disorders global patient survey and registry, and encourage enrollment in clinical trials. And as you're all aware, clinical research is the only way where new drugs, novel drugs, and curative therapies have come to the market. Clinical research is critical to scientific discoveries and medical innovations. And there are so many ways of clinical trials. The randomized clinical trials are gold standard designed to evaluate and efficiently translate research data into clinical practice. So in order to be able to move forward in this field, we need to participate in clinical research because that's a gateway to potential life-saving novel therapies even before the therapies become standardized. Why is that important? Because that can lead to improving patient outcomes and health-related quality of life. Unfortunately, clinical research took place in academic medical centers prior to recently. However, research in community hospitals in many parts of the world, other than the USA and Europe, has emerged recently. So why is it important really to have this collaboration in global research? Because we all know that there are endemic areas, there are clustering of some of these diseases. Think of sickle cell disease, the biggest clusters in Africa, sub-Saharan Africa, India, the Middle East, the MENA region. Think of thalassemia, the Mediterranean region, or Eastern or the Far East. So that these medical centers and healthcare providers in these areas of high prevalence see large volume of patients, but unfortunately, they do not participate in clinical trials because of many barriers. Limited availability of research program, physician leadership, you need a leader and an experienced investigator. Lack of infrastructure and capacity, you need a CRU, IRB, CRCs, CRAs, all of those you need. Decreased sub-investigators, decreased patient caregiver awareness of need and benefits because there's a suspicion, there's really doubt and lack of confidence in healthcare providers about, sometimes enrollment in clinical trials. Limited communication. Yes.
Yes, I'm so sorry to interrupt. Thank you so much for your talk so far. We're just having a bit of an issue seeing your slides. They're not advancing. You're continuing to advance them on your side, are you?
Yes, of course. Which slide are you seeing now?
Unfortunately, we're still on slide number 1.
Oh, I wish you told me before. I'm sorry for that.
No worries. We were trying to troubleshoot in the background a little.
Let me share them again. Let me stop and share them again. Okay. Mm-hmm. Do you see them now? Do you see my screen now?
We do see your screen there, yes. Okay, so if you want to go back into presenter view.
Of course. Yeah.
Thank you so much.
Okay. Well, okay, do you see global research
They are
now?
Advancing normally now, yes. Thank you so much.
Sorry,
please continue. I'm sorry for the interruption.
It's okay, no. And that limited communication and sharing of resources between research investigators and academic centers and community hospitals. So it's very key that people living with inherited blood disorders and their caregivers for children be educated about the needs and benefits of research. And it's key that they can serve as advocates for clinical research with their peers, because people with inherited blood disorders sometimes listen very well to their peers who have been enrolled in clinical research. So from what I've told you, we seem to be sitting globally on a genetically determined time bomb. It's time for action. for improving outcomes of people with sickle cell disease and other inherited blood disorders, despite the excellent work by some global organizations. So do we think can GANSID move the needle? And when I thought about that, I thought about my career goals and how do they fit together. So my career goals, when I decided to leave Boston to take over my late brother's clinic when the war was in Lebanon, I had clear career goals. And that was to cherish collaboration and unity among healthcare providers with diverse perspectives and experiences in all areas of hematology, have a long-standing commitment to combating inequities and injustice in hematology in Lebanon, which does exist in the MENA region and globally through integrated and community-based care and collaborations, empower patients and the healthcare community to raise their voices high, improve enrollment of participants with rare blood disorders in clinical research, and our center is currently involved in at least 25 global trials in inherited blood disorders. And finally, accelerate science and optimal healthcare delivery globally and improve the outcomes for individuals with inherited blood diseases. So these goals are really not that far from what GANSID is trying to do. So GANSID, you've heard, is a unifying global network. Its goals are clear: improve care infrastructure, healthcare providers training education, patients access diagnosis, safe treatment, care and research. And the tools are very solid and robust: education, research, advocacy, and capacity building. Understanding patient journey is very important and will lead important information. And it will create patient leaders, and that's what's important, and expanding advocacy, because patients can be the best advocates. And being part of policies or promoting policies that eliminate health disparities in patient care. So GANSID briefly aims for a world in which having an inherited blood disorder is less terrifying for patients, but also less distressing for healthcare professionals through a collective work that provides equitable care and improves outcome for people impacted by inherited blood disorders. And I'd like to end with this African proverb that really delivers a very clear message and interesting message. If you want to go fast, go alone, but you don't want to do at all in GANSID. If you want to go far, go together, and let's put our hands together, because that's the way to do it. Thank you for your attention.
Excellent. Thank you so much, Dr. Inati. I think that's a wonderful quote to summarize this part of this session and really the entire Congress, that we're looking to go far by going together. I'd like to open things up at this point for some questions. We have time for a Q&A. And while we're waiting for some of those questions to be posted in the Q&A or in the chat at the bottom of your screen, there are a couple of questions that we can start off with for Riyad and for Adlet. I think a large question is about the markers of success. So what are some of the ways that we can look to measure the effectiveness of GANSID?
That's a very good question, Jennifer, because, I think it's very important when you think of measures of success to have clear objectives and to have clear indicators of success. So, for example, I can think of projects that are clearly associated with success, like, for example, newborn screening, like starting hydroxyurea, which is going to interfere, is very important for improving care. Because in GANSID, in as much as we'd like to advocate and educate, I think it's very important to have projects that will be translated positively on patients' outcome. So this is one of the projects that I think is an indicator of success. If we can, for example, be implemented in providing hydroxyurea to areas of high prevalence, and there are so many, and also supporting point of care diagnosis, newborn screening by point of care, that would be very important. But one additional point I would think of is started contact surveys. to be able to know how big is this problem we're talking about. Of course, World Federation of Hemophilia has conducted great surveys, Fanconi Anemia Foundation, many of the sickle cell foundations, TIF as well, but we don't have a global survey of these disorders. Why is it important to get these surveys? It's important to get them and analyze the data, because that analysis of data can result in concrete outcomes which will guide us or support us in writing any guidelines or having any conclusions that are very important. And one other thing, I think, how effective would GANSID be in involving governments? Because we know in areas like, the medium and low resource countries, governments have to be involved. The First Lady or the President or whoever it is. So have we been effective in involving governments and successful as, for example, as World Federation of Hemophilia and the GAP program? These are indicators to me. They're not only projects, but indicators of success. It's not doing that. Can we do that? If we can do some of those, I think that would be good indicators.
Fantastic. So quite the to-do list that GANSID has in front of it, for sure. Riyad, was there anything you wanted to add there?
I don't think there's anything to add to this, but just one minor thing that in this similar, like one of the successes we've seen in thalassemia is countries that have low numbers of new incidents of thalassemia, new birth. So that's another measurement outcome. And usually when you have achieved a very good level or like zero birth in 1 or 2 years, that's an indication that the society has learned, the awareness has really worked on this, and that will free up resources for other patients and for, the patients that are struggling. I want to actually ask a question, and I like that. And this is sometimes me as a patient and others, we don't think of that. Dr. Annette, you had on your slide towards the end, make it less distressful for doctors.
Yes.
And I really like that. And I think that's very important. So how do you think we could get that? Or, I mean, that to me, I think that would be another measurement. But how can we achieve it or get some improvements?
One of the reasons why people living with these disorders prefer to stay with their pediatric hematologist is that empathy and that family relation with them. Our patients, for us, at least I can speak for myself and many of the people who work with benign hematology, our patients are family, which means that we don't take care of them only in terms of their health. We try to help them in terms of their jobs, in terms of their schooling, in terms of their frustrations, family issues, and when they have a problem, I mean, it's our agony. And they really feel it. As healthcare providers, I always say, if we are not merciful healers and we feel the agony and the pain of our patients, we cannot move anywhere. Honestly, we cannot. And this is one of the reasons why you and I and Jennifer and Larry and all of us are together. Why are we together if we don't have this merciful healing part? We wouldn't worry about that. So this is what's going to make us, I think, unique, GANSID unique in working with this in this spirit. So we are really, I have lots of agony when any one of my patients has pain or God forbid dies from cancer. It is, and my family knows that. They feel it.
I think that's a wonderful point, and that this all comes back to our shared humanity, to the importance of empathy in this work and in these relationships. I'll ask you one last question in the last moment that we have remaining for this session before we move on to our poll. The opportunities for collaboration within GANSID. We heard from Cesar Garrido at the beginning about partnerships around the globe. And I wondered if either of you had thoughts about what high-resourced countries and organizations may have to learn from lower and mid-resourced countries and organizations about meeting the needs of people who are living with inherited blood disorders.
Riyad, would you like to start?
Yes, well, in my opinion, I mean, high resource or low resource, they all deal with some of the same issues. One of them is how do you have equitable care, and because we see that like in Canada, for example, the US, the UK, those who live near major urban centers, big cities, they get very good treatment, and those who live in remote areas get much different treatment. Um, so that is not it's not really a resource issue. This is more an issue about knowledge, about training, the healthcare professionals, or providing education, more awareness, um, teaching the patients to self-advocate effectively. These are what you see in the low resource countries, but sometimes it's different. I mean, in low resource countries because you don't have resources, but in the very rich countries, what are your excuses? So you have to learn from that, and also you could learn how you could, like, these guys make so much out of like whatever they have. Why don't you do the same in the rich countries and save up some resources?
Yeah, that's very true, Riyadh. And if I may add to what you very clearly said, a few examples about how low resource countries can transfer their experience to high resource countries. We know these countries have many, many patients, and these healthcare providers have long experience with utilizing affordable, cost-effective medications and diagnostic modalities. For example, if you look at the state, some of the point-of-care diagnostic tests for sickle cell disease, that point of care is much cheaper than HPLC or hemoglobin electrophoresis, and its sensitivity and specificity has been proved scientifically, and the data is published from Africa. So that's one way. Rather than paying a certain amount of money for HPLC, we can do point-of-care testing, which is way cheaper. That's number one. Number two, the dose of hydroxyurea, for example. Dose of hydroxyurea, generally we say we start with 15 milligrams per kilo and then escalate it to maximum tolerated dose. In Africa, as has been shown, if you use low dose, you may be okay. I mean, it's not the end of the world. The patients are doing much better, even in patients who are at high risk of developing stroke and who are supposed to take 1 year of transfusion and then hydroxyurea. So data on hydroxyurea, low dose has been successful. And the last example, if I may have just 1 second, the last example is also for hemophilia. For example, data from India on hemophilia has shown that when you give prophylaxis, and that's a standard of care now, there are 3 modalities. You can use the high dose, very high dose, regular, and low dose. In countries with limited resources, the low dose, which at least 50% less than the high dose, has been quite successful in minimizing the number of bleeds and the annual number of bleeds, surgical bleeds, all kinds of bleeds. So this is how they learn. I think these are 3 examples. They can learn a lot from them.
Thank you so much. And those are excellent examples. We have another couple of questions that have come up in the Q&A, but unfortunately, we've come to the end of the time for our session. I'd ask if Riyadh and Adlet maybe can answer some of those questions in the Q&A by typing. And I would encourage everyone who's participating to reach out to the speakers throughout the Congress through the FeedLoop platform as well. At this time, we're going to open a poll for some feedback about this session. You'll have about 4 minutes to complete the poll. Please do take a moment so that we can continue to learn from these sessions and ensure that that we continue to provide excellent content for you. After the poll is complete, so at 9:55, we invite you to join us for the next plenary session, Making the Promise of Innovation and a Reality for All, Global Access to Gene Therapy and Other New Therapeutic Approaches. And again, that's going to be starting at 9:55. I would like to express my gratitude. Thank you to Cesar Garrido for an excellent session, to Riyadh Elbard for his in NADI for a very informative talk that I'm sure has benefited everybody who's listening today. So thank you to all three of you for participating in the plenary session today. And everyone who's listening, please do take a moment to complete the closing poll before joining us for our next plenary, which will be starting at 9:55 Eastern Time.